Hello, everyone, and welcome to Ortho NorCal Educational Webinar Series. We hope everyone is staying safe and healthy and enjoying the beautiful weather. My name is Leah Rutinov, and I'll be the moderator for today's webinar. And I'm honored to host this event together with Dr. Jeffrey Cannell, who is pediatric orthopedic surgeon at Ortho NorCal. Today's webinar topic is the surgical treatment of Pectus excavatum, which is also known as sunken chest, and it's intended for patient education only. We will have our Q&A session after the presentation, so be prepared to send your questions to us using Q&A or chat buttons at the bottom of your Zoom screen. If you have any additional questions after the webinar, you can always email us at info@orthonorcal.com or call the office directly at 408-412-8130. With all that being said, I'd like to welcome our presenter. Welcome, Dr. Cannell.
Hello, everybody, and I'm glad everybody has been able to join us today. I'm going to share my screen here now. So I'll give a talk on Pectus excavatum, and then as Leah said, after the talk, during the talk, you can send questions to Leah, and I'd love to answer your questions after the talk. Hopefully everybody can see this now. There should be a screen there with a picture on it. You see that, Leah?
Yes, it looks great.
All right, good. Okay, so this is my personal experience treating this condition over the last 20 years or so since I've been actively treating this problem. So I guess you guys all just saw my picture, but this is me and my specialty. The general classification of Pectus deformities are deformities of the chest. And what they really are an abnormality of the little connecting cartilages that connect between the end of the rib bones and the breastbone. And these pieces of cartilage that connect the ribs to the breastbone become misshapen. And in general, we look at two different types of Pectus deformities. Pectus carinatum is, some people also call pigeon chest, is where the breastbone or these cartilages will protrude outwards from the chest. And Pectus excavatum, which we'll spend most of our time talking about today, is where the middle of the chest is sunken inward. So here's a picture of both conditions. On the left side of the screen is a typical appearing Pectus carinatum, where you can see the breastbone and the edge of the cartilage there protrudes outward from the chest. And to the right side of the screen is a fairly typical appearing Pectus excavatum deformity. They occur, I would say, roughly equal between males and females. Pectus excavatum affects about 1 in 1,000 people. You don't see it in very young children or at birth, or at least it's pretty unusual to do that. Most people that get this have maybe a very slight amount of Pectus when they're young, and then something around age 11 or 12, it starts to progress and become more noticeable and more severe, both the Pectus excavatum and the Pectus carinatum. With Pectus excavatum, as the sternum becomes more and more compressed, the heart and the lungs become displaced and really change. And you'll see a little bit of an example of that in a minute. The traditional treatment historically of Pectus excavatum was an open repair with a very large incision across the chest where pieces of the ribs and the sternum or the breastbone and these cartilages are resected and then wired together It's really not done as a procedure in and of itself anymore. It caused a lot of scarring and a very rigid chest wall. And this very innovative doctor from Norfolk, Virginia, who originally is from South Africa, but was working in Norfolk, Virginia, devised this other procedure about 25 years ago, which has really taken over as the primary treatment for this condition. It is a very minimally invasive procedure. There's literally almost no blood loss. There are two very small incisions way on the sides of the chest under where the arms hang down. So there's really no visible scarring at all. There's no excision of bone or cartilage. It relies on remodeling, or where these cartilages that are misshapen over time become more normally shaped. There's a bar inserted that you'll see, and the bar holds the chest in its new shape while these cartilages change shape and change the shape of the chest. And so ultimately, when you remove the bar after 2 or 3 years, the chest retains its normal shape. The doctor that devised the procedure is Dr. Donald Nuss, practicing in Norfolk, Virginia, and he's a pediatric general surgeon. The indications of treatment are really between the ages of 4 and 20. I've done a very few of these procedures in people older than age 20. It's very difficult, and as a primary treatment just for Pectus excavatum, except in very specific circumstances, it's really is better. And by younger, I mean ages 8 to 10 up to about 15. That's the ideal time to do this type of surgery. It does progress in adolescence. The symptoms that people get from Pectus excavatum are exercise intolerance, meaning as you run or are active, you just feel like you can't get enough air. And that's because the chest is narrowed. Some type of chest pain, and it's a vague complaint. It's not specific sharp pain, but it's more of an achy feeling. A feeling of shortness of breath, even at rest. And it can cause cardiac and lung problems from both the heart and the lungs becoming displaced or squished. And it can cause heart arrhythmias or abnormal heart rhythms, and other specific problems with the heart or the lung. Here is a CAT scan of somebody with Pectus excavatum, and you can see the white flat structure on the top there is the breastbone or sternum. It's a little bit crooked, but you can see from the shape of the chest wall, it's pushed in. This round thing here, all this here is the heart. And the heart's normally more right in the middle, and you can see it's pushed towards the left side of the chest. You can see down here is one of the backbones, and you can see it doesn't, where the yellow line is, it doesn't leave much space between the breastbone and the backbone. A way that we quantify the severity of the deformity is we take a ratio of the width of the chest on the most compromised image, which in this particular person's case was this. So that's the red line. So we take the width of the chest and divided by the height of the chest, which is what the yellow line is. And if that number is greater than about 3.3 or 3.4, then the deformity is considered significant enough to warrant surgical treatment. And you can see the red line is much more than 3 times or 3.5 times the length of the yellow line. So this would be a clear case where operative treatment would be considered. The treatment can be observation in somebody with a mild deformity and you just want to see if it's going to change. There is a brace. The brace, in my opinion, we're much more successful using to treat the pectus carinatum deformity, where we push that pointy part of the bone in rather than trying to push the inner part out. I give the analogy of like a Coke can, and if you have a dent in the Coke can, you can press on the sides and it'll pop the indentation out. And it works okay, but not really very well. It's easier to push just on the top of the protruding area and push that in. And that actually works very well, and we do treat pectus carinatum fairly routinely with a brace that was developed elsewhere, but we've modified locally. And I'm going to show you, this is a very old slide, probably almost 20 years old, of one of our first braces. They don't look like this at all anymore. They don't have screws that stick out. The part that's sticking out now, it's two pieces and there's Velcro on the side. So it really doesn't protrude and you can't really see it through a shirt. And it's pretty well tolerated by teens. But you can see the idea. There's the front of the brace and there's the back of the brace. So you need some counter pressure in the back. And like I said, the one we use now doesn't protrude out from the sides anymore, and it's very well tolerated. I'm now going to show a video of the procedure. We've edited it. I don't think it's too gruesome at all. It doesn't show any blood, but it does show actual surgical images. So if you get squeamish, the video itself is about 3.5 minutes long. So you can look away for 3.5 minutes. I am going to narrate the video. So here we go. So this is actually Dr. Nuss, and he's measuring a patient that's going to get a bar. Those orange pieces are templates that we can use on the chest to help us. And this is going fast, but that was bending the bar. And that's what the bar looks like on the outside in the operating room before we insert it. I'm just trying to get it to fit just right. So this is showing the mark in the middle is the deepest part, and the marks on the side are where the bar actually would penetrate the chest and go underneath the breastbone to push the sternum back outward. And here we're just measuring on both sides to see exactly where we're going to put everything. Sorry for the little bit of interference. That's a scope, and the orange thing is a port, and the scope is going into the chest through a very small incision. And there's the heart, and the stuff on the top is the sternum poking in. You can see the heart beating. And in the upper left portion of the screen, you're going to see an instrument go penetrate between two of the ribs. So we're not cutting bone. And this instrument's going to poke in, and we're going to open it to just give us a little bit of space here. So that's where the bar is going to go into the chest. And now we're going to put what we call the introducer in. And then we're going to walk that across the middle of the chest under the breastbone to the other side. And you'll see it going across. That's in front of where that is. Right there is the deepest part of the breastbone. Sorry about that. So we're going to go all the way across to the other side of the chest. And right about there, we're going to push up. And that's the corresponding location on the other side of the chest, and push the tip of that back up between two ribs on the other side of the chest. And then we'll bring it out on the very side of the patient's skin, so you don't see the incisions at all. So that's now going to go up in a soft spot. And there's the introducer from the outside, turning it around. Here is the bar, the actual bent bar, you can see the string that we're using to pull it across the middle of the chest. And we're gonna pull that across. You can see the bar on both sides and it's moving because right now it's sitting on top of the heart. These two things turn the bar upside down so it's pointed the right way. So we put it in upside down and then we flip it like this. And you can see in the middle of the chest, boom, it pushes the breastbone back outwards and the problem is connected. And then we put these small little connectors onto the sides of the bar like this, and you'll see it going into a bar like that. It goes on the edge, and those ridges are to have some suture, and the holes are to help suture the bar in place so that it, so that it, the bar stays where you want it to be. So that's how the procedure is done. It's about an hour procedure. It doesn't take very long, and you can see it's not bloody at all, and it's instantly corrected. So here is a picture of a person with a typical pectus deformity. This was one of the first patients I did this procedure on. That's what he looked like before, and this is very shortly after his procedure. You don't see any scars on his chest because they're under his arms on the side. And you can see between that and that, you can see a very nicely corrected, normally shaped chest. So now there's much more room for the heart and lungs, and it takes care of the pain that people have, and it takes care of the exercise intolerance that people get that have pectus excavatum. This is what a bar looks like on an x-ray. You see this person has some very mild scoliosis as well, but you can see on the side, the two little stabilizers, we call them, on the edges of the rod that we suture into place. And then you can see the bar going across the middle like that, pushing the chest out. People are usually in the hospital 2 or 3 nights after surgery, and it's almost only for pain management. We use an epidural catheter or a small plastic tube that gets put in right before we do the procedure in the upper part of the person's back that we can use to keep the area numb or give pain medicine, and it provides very excellent pain relief. And then we take that out, usually the second day after surgery, and switch people to just pain pills. And by 7 to 10 days after surgery, pretty much nobody is on any pain medicine anymore. Walking and swimming are okay immediately after surgery. We give people deep breathing exercises to do to re-expand the lungs after surgery. We limit lifting and twisting for about 6 weeks and show people how to move while they're in the hospital. And after 6 weeks, except for contact sports, people can go back to normal activity. And then even contact sports such as football or ice hockey can be done at 3 months. We recommend in all cases that the bar is removed between 2 and 3 years after surgery. Excuse me. And the bar removal process takes a very short amount of time. We do it as an outpatient. Nobody has to stay in the hospital after this. There's really no pain after taking the bar out, and people can go back to normal activity almost immediately after bar removal. So in conclusion, it's a very, very safe procedure. You are close to the heart, but we do this under direct visualization with the scope. As you saw, we can see everything that we're doing, so it's very safe. It's very cosmetic. There's very good 25-year history showing documented maintenance of correction after bar removal and improvement in cardiac and lung function up to even 10 years after surgery people have been evaluated and have markedly improved function after the procedure is completed. So thank you for joining us. I hope people have submitted some good questions. I'm going to unshare my screen now so you can see me as I'm answering the questions.
Thank you, Dr. Kennel. Very informative presentation. And I gotta say that I'm pretty sensitive with all the videos, of procedures, but that video really showed how the procedure is done, and it was very informative. So thank you for sharing. I'm gonna dive into Q&A session. If you have any questions, please send those over to us by using Q&A or chat buttons on the bottom of your screen. I do have a couple of questions to start with. The first question is, how long is the recovery from Pectus excavatum? I hope I pronounced that correctly, surgery.
So like I said in the presentation, there's three parts to this answer. Part one is, like I said, maybe 3 nights in the hospital. In terms of needing medicine for pain, by 10 days or so after surgery, most people don't have any pain anymore and are not taking any more pain medicine. Kids that are done during the school year, by 2 weeks after surgery, can easily be back in school. The second part is we restrict some movement and lifting for about 6 weeks. And by 3 months, any activity is fine and people are really not symptomatic. I typically see people back after surgery, first about 3 weeks after the procedure, then about 3 weeks after that as they're going back to normal activity, and then maybe at 3 months, and then at a year, and then at 2 years as we start to plan the bar removal.
Thank you, Dr. Kennel. The next question, how common is this condition?
So in the general population, about 1 in 1,000 people. Severe enough to require treatment. I can just speak from my own experience. I see about 2 new patients a month with a pectus deformity. Some are pectus carinatum. Some people don't require any treatment. It's very mild and they just want to know what it is. The pectus carinatum patients that want it, we use this brace for, and the brace is worn. I didn't say this during the presentation. The brace that we use for pectus carinatum, usually within about 6 weeks of onset of brace treatment, and the brace is worn 24 hours a day. It's removed for any type of sport or physical activity, and you sleep in it as well. By 6 weeks after, usually the deformity is corrected, but you have to wear it about 4 months full time, and then part time about 6 to 9 months to get long-term maintenance of correction from using the brace. In terms of how many people that I see require surgery, of the 2 or so new patients a month I see with this, I would say about 1 out of 4 are candidates for that have pectus carinatum are candidates for surgical treatment.
Thank you, Dr. Kennel. Next question. Can a high school age student athlete play contact sports with this condition? Are there any contraindications to any sports? And how many of these procedures have you done?
So for the first part, depending on how much shortness of breath you have, a lot of teens, as they get more active and as the deformity becomes more severe, have more and more difficulty participating in sports. And that's why they come in. They're getting short of breath and they're having pain with activity. And that's when they get interested in treatment. It's not really done for cosmesis, although I'm sure people appreciate that they look better. It's done because people are having difficulty with catching their breath or getting enough air while they're exercising. And that's why people have the surgery. How many have I done? I've probably done about 200 of these at this point.
Great, thank you, Dr. Kennel. The next question: how old is the patient who was in the presentation, and what is the youngest age to do the surgery?
So I assume, how old was the patient that was in the video that we were operating on?
Right.
That video was made about 15 years ago. It was a teenager. So I'll just guess right between 12 and 14. That's really about the typical age that we do these. We'll do them a little older than that. And you can do it. They make bars that are teeny tiny. I don't even know why they make them as small as they do. It's so small that I don't even know if it would be that it's too small for an infant. I don't think I would ever want to do this on an infant. I think, so the exception would be, you could, in theory, have a very small child with such a severe pectus excavatum that they really can't wait till they're older. It really is compromising their ability to breathe. And you can do it in a very, very young person. We have very, very small scopes, and size is relative. So we have instruments for very, very young children, and you can do it on a child, I would say safely at age 5. I think the chest would be large enough to be able to do the procedure. But I would only do it on a patient that young if they were really compromised and couldn't wait. Otherwise, I would try and wait till at least age 8 to 10. I think that's a comfortable age to do it.
Thank you, Dr. Kennel. The next question: there's apparently also a vacuum bell method to treat pectus excavatum. Do you have any experience with this, or do you find you need to do the surgical bar method due to vacuum bell not being effective?
So I'm not familiar with a vacuum type procedure, but there is a procedure developed at UC San Francisco that uses a magnet. And so what they do is they implant a strong magnet under the breastbone, and they put the patient in a brace, and that has a magnet in the front of the brace. And it's a shell, it's a big plastic shell that they use, not like the brace I showed. And so there's a surgical procedure to implant the magnet and an incision on the front of the chest. And then the magnet pull on each other and pulls the chest out slowly. From what I understand, it takes 2 or 3 months to get correction using the magnet, and then you have to maintain it for a while afterwards, and then you go back in and take the magnet out. So for me, the reason I have no experience with it is you're doing 2 operations anyway. You're making a more uncosmetic incision because it's right in the middle on the front of the chest. You're putting this magnet in, you have to go back and take it out. And then you're relying on the ability of the brace and the magnet in the chest to correct the deformity. And so results are variable. I don't know if they're still using it or not. But that was the procedure. And I have seen several patients in the middle of this treatment that weren't exceptionally happy with the results that they were getting from the magnet. But I have no personal experience treating somebody with it.
Thank you, Dr. Kennel. The next question: how can I fix my sunken chest without a surgery?
Well, so if you're 15 years of age or younger, I do treat some people with a brace if they choose. It's different than the brace that I showed. It pushes on the top parts of where the chest is the highest on both sides, and it can push the middle out. In some people it works, in some people it doesn't. I do use that in people that request it. If you're over 15, there probably isn't a way to fix it. I've operated on just a handful of adults, some with other conditions that required treatment. It's very difficult The chest is more stiff. The cartilage doesn't bend as well. It's very difficult to do. I'm sure there are people that are experienced with the old-fashioned procedure where you cut the bone and use that to reshape the chest, and that can be done, which is also a huge operation. Most of the time, people that really are symptomatic with this know it by the time they're at least 17 or 18, and I will treat somebody that age if they want it. A lot of times, if you're treating someone a little bit older, you need to put 2 bars in, and then that works out pretty well. And yeah, I have several people like that I'm in the middle of treating right now. They get good results. We get better results in a little bit younger person.
Thank you, Dr. Kennel. The next question. Can Pectus excavatum return after surgery?
So apparently it can. I will say, I'm very careful about when I remove my bars. I have never had a patient come back with a significant recurrence of their pectus deformity after bar removal. I tend more towards the 3 years than the 2 years. On anybody over 12, I leave it in really for 3 years. And that seems to be long enough that once you remove the bar, everything stays in place.
Thank you. The next question. How much does a NUS bar weigh and what is it made from?
So the bar is made predominantly of stainless steel. That's the primary bar that we use. There is a titanium bar available for people that have nickel allergies, where you can't put stainless steel into them. The reason we use stainless steel is, unlike titanium, it holds its shape better once we've bent it. It stays and works just a little bit better, but you can use a titanium bar if required, and it works just fine. And it weighs less than a pound.
Thank you, Dr. Kennel. Next question. Does Pectus excavatum worsen with age?
So I don't have any experience in what happens to adults with Pectus excavatum that aren't treated. They generally are satisfied and don't come to the doctor, or they don't have serial visits with time. So I don't know after the end of growth if the deformity continues to worsen. My feeling is it likely does not, that it's the worst it's ever going to be by the time you're 16 or years old or so.
Thank you. The next question. Does Pectus excavatum shorten lifespan?
No. It may diminish the amount of activity somebody can do. You can get certain types of irregular heartbeat that might require treatment. Somebody where it's going to be that severe, like I just said, they know they're having those problems when they're teens and can have the problem fixed, and then all those things go away. So the severe ones probably get treated surgically now, and the less severe ones, it doesn't really shorten lifespan.
Great, thank you. The next question. What kind of anesthesia is used during the procedure?
We put the epidural catheter, the little plastic tube in the back, right at the beginning of the procedure before we start. And then medicine can be given in that during the procedure, which decreases the amount of pain somebody's having while they're asleep, having the surgery done. So they require less general anesthesia, but everybody gets an epidural and a general anesthetic.
Thank you, Dr. Kennel. This is just a general question. I guess it applies to all the surgeries. How safe is it to get a surgery done during COVID?
So that's a very good question. At this point in time, it's very, very safe. I think that was an issue last March and April when we were just getting a handle on things. But every single person that walks into a hospital now is screened at least and asked general questions. People are aware of the symptoms of COVID and hopefully don't go into the hospital if they're actively sick. And every single patient being treated in the hospital is being COVID tested before surgery. So we don't operate on people that have active COVID unless it's life-threatening. And we know who everybody is that has COVID. If they have to go to the operating room and have a COVID-related procedure or an unrelated procedure that is life-threatening, we know who they are and we take precautions, and the patients are isolated in separate units. So it's, right now, it's safe.
And the second part of this question, what hospitals do you have privileges at?
I have privileges at O'Connor Hospital, Good Samaritan Hospital, and El Camino Los Gatos Hospital. I suppose I actually, in theory, have privileges at El Camino Mountain View Hospital, but I don't actively practice there.
Thank you, Dr. Kennel. And the last question for this presentation is, one second, I lost the question. How does the minimally invasive approach different from the old surgical repair?
So the old surgical repair, there's an incision made across the front of the entire chest. It's a very long scar, about 10 or 12 inches long. And the breastbone is cut once or twice. Multiple ribs are cut. There is a type of a bar different than this one, although you could do it with this bar at this point in time, that's put in an open fashion and sutured or wired to all of the ribs and broken pieces of bone to hold them in place while it's healed. I saw one once that was being done by a cardiac surgeon many, many years ago. And when I was, right at the time I was thinking about starting to do this procedure and learning about it, and I decided I would never do this other procedure because it did not look like something that people would really be interested in having anymore, that this other procedure works so well. But if you were an adult, back to a previous question, if you were an adult and you had to have this done, you would have to have some hybrid procedure between the old style and the new style. It would have to involve actually physically cutting of some bone to reshape the chest. There would be no way to do it the way we do teens. It just wouldn't be effective.
Thank you, Dr. Kennel, and thank you all for joining us today. We hope you enjoyed the webinar, and if you have any additional questions, please feel free to email us at info@orthonorcal.com, or call the office at 408-412-8100. The webinar recording will be available on our website under News Past Events, just in case you'd like to share it with friends and family. Thanks again, and enjoy the rest of your day. Thank you, Dr. Kennel.
And the video will be online too for people that want to see it again.
On our website, and also for all those participants that registered or didn't get a chance to join us. So yes, it will be available for everyone.
Thank you. Bye, everybody. I appreciate you listening.